Ladies and gentlemen, colleagues and friends, during the next 10 minutes, I'm going to present you the background, the motivation, the methodology, the results, and the implications of our clinical study, improvement of vertigo symptoms after 2 months of Vertigoheel treatment, a case series in patients with bilateral vestibulopathy and functional dizziness. At the beginning, I'd like to show my conflicts of interests. I think they are quite well balanced, and some of the videos and slides I'm going to show are from our recent book on vertigo and dizziness. We have performed this study in 2 diseases which are characterized by persisting dizziness and imbalance, and where there is a high medical need for an effective treatment. Each of the diseases will be introduced by videos and as a kind of quiz, and I hope you can make the correct diagnosis. Listen to this gentleman, please.
Goetz, which symptoms do you have that you've come to us?
Vertigo and walking disorders.
How long have you had these symptoms?
For a good 3 years now.
How is it when you're lying and sitting down?
It's okay when I'm lying and sitting down.
Standing?
Actually, standing too, with slight back and forth movements.
How is it when walking?
When I walk, I notice when I'm not focused, for example, that I break out to the left.
How about walking in the dark or on an uneven surface?
Then it's even more difficult for me, because I notice that I really fluctuate then. And the bottom line is that it's very difficult without light.
How about cycling, if you have to stop suddenly?
When cycling, it is very difficult to focus. You also have eye movements, so a vibration is the bottom line.
Thank you very much.
So, do you have an idea about the diagnosis? It's the most frequent cause of persisting postural imbalance, dizziness, with an increased risk of falls. And the diagnosis can be easily made by the so-called head impulse test. So this is a patient with bilateral vestibulopathy, and here are the diagnostic criteria which we published in 2017. It's a chronic vestibular syndrome with the leading symptoms of unsteadiness of stance and gait and movement-induced blurred vision or oscillopsia due to the deficit of the vestibulo-ocular reflex. Typical symptoms are worse in darkness and on even ground, and typically patients do not have symptoms under static conditions while sitting or lying down. In most patients, the etiology remains unclear. There are several treatment options. First, very important, explanation and consultation. Tell the patient why he or she feels dizzy. What is required in every patient is daily, permanent, and lifelong balance training, prevention, as in Meniere's disease, if possible, treatment of the underlying disease, same for Meniere's disease and some autoimmune diseases. At the horizon, we have the vestibular implant and other devices. In a cohort of patients with bilateral vestibulopathy, we performed this prospective, non-interventional, monocentric case series. Treatment duration was 2 months. The dosage of Vertigoheel was 3 tablets per day. We analyzed 13 patients with bilateral vestibulopathy and included 41 patients with functional dizziness. The primary endpoint for both cohorts was the Dizziness Handicap Inventory, a well-established scale. Secondary endpoints were body sway and quality of life, and in addition, for patients with functional dizziness, anxiety and depression scores. Here are the major findings of the primary endpoint of the patients who suffered with bilateral vestibulopathy. The Dizziness Handicap Inventory decreased on average by 13 points from 45.4 to 32. That was a significant improvement of the DHI, which is also clinically meaningful. So here a summary of bilateral vestibulopathy. We mentioned the typical signs and symptoms, etiology unclear in about 50% of the cases, and a theoretically new treatment option, in addition to what is mentioned here, is the use of Vertigoheel as a long-term treatment, which, however, has to be examined in a future placebo-controlled randomized trial. Now, listen to the next patient, and maybe you can make the diagnosis.
Mr. Kuhmann, you came to see us because you suffer from persistent dizziness. When did it start?
Probably 20, 30 years ago, I'd say. So a very long time ago.
How is it when you're lying down?
I feel no different lying down than I do standing up, for example. That is, the symptoms are there even when I'm lying down.
What about walking or running?
Not so much then.
What about when you walk in the dark?
No difference, really. No issues.
How about when you have to concentrate hard on something?
Well, I think that when I'm distracted, I don't notice it so much.
And when you're playing sport?
I barely notice it when I'm playing sport.
And after a glass of beer or wine, how is it then?
I don't think it makes any difference.
What is it like in department stores, crowds, in open spaces, confined spaces?
Completely fine.
Not worse?
It doesn't make it worse, no.
Is there anything you avoid due to the dizziness?
Not really, no.
Thank you very much.
You're welcome.
I think it's very easy for you to make the diagnosis of functional dizziness. And functional dizziness is the umbrella term for different subtypes. Please do not call it psychogenic, somatoform, or even psychiatric dizziness, which will harm the doctor-patient relationship immediately. So from now on, use the WHO-approved term functional dizziness. There are, as I said, different subtypes: phobic postural dizziness, persistent postural perceptual dizziness, visually induced dizziness, and rarely mal de débarquement syndrome. Here are the clinical features of functional dizziness. So it's subjective instability of posture and gait. Neurological findings are normal or cannot explain the patient's symptoms. The symptoms often fluctuate. There can be triggers like crowds of people, empty rooms, department stores. In addition, if you ask for, many patients report that there's an improvement with light alcohol consumption and during sports, because then the patient is distracted. Typically, as we showed in a study, patients have less symptoms in the early morning because it takes a while until they move out their antennas. Some patients develop avoidance behavior. Personality traits, usually compulsive. Patients are perfectionists. They would like to have everything under control, including their balance. And finally, in about 25% of the patients, there is a disease at the beginning of functional dizziness, so-called secondary functional dizziness, and patients can suffer from 2-3 different types of vestibular disorder. I call it vertigo to the power of X. Therapy, well, there are basically 4 therapeutic principles. However, there's so far no placebo-controlled trial. That means there's a high need for new treatment options of functional dizziness. The regular therapeutic procedures are a complete diagnostic workup to remove any fear of having a severe illness. Secondly, explain the mechanism of the disease to the patients, including provoking factors. Thirdly, patients have to perform desensitization by self-exposure and regular light exercise. Vestibular exercises are counterproductive. And some patients need either behavioral therapy or pharmacotherapy. However, no placebo-controlled trial yet. And here are the results of the study, which I mentioned before. Also in functional dizziness, the dizziness handicap inventory significantly decreased here by 12 points from 46 to 34. So that's a clinically meaningful difference. We also evaluated quality of life and anxiety and depression. And here again, we could find in this cohort of 41 patients a significant improvement of quality of life, as well as a reduction of anxiety and depression. That means the drug has a multimodal, either direct or indirect benefit and mechanism of action. If we talk about mechanism of action, animal studies are most helpful. And this year, 2 studies were published in 2023 with animal models. On the left side, this study showed that Vertigoheel improves central vestibular compensation after acute unilateral peripheral vestibulopathy. And as you know, in animal studies, there's practically no placebo effect. So it definitely has an impact on the vestibular system directly and indirectly. In addition, as you see on the right, Vertigoheel also improves cognitive performance in memory tests. That means the mechanism of action is multimodal. It acts on various levels, areas, and circuits of the brain. So in this study, we showed an improvement of vestibular symptoms in 2 cohorts with persisting symptoms, bilateral vestibulopathy, and functional dizziness. By the way, functional dizziness is the most frequent cause of dizziness at all. Thank you very much for your attention.